When sourcing the correct equipment for your veterinary procedures, there are 4 key things to consider. 1. Is the design suitable for the procedure at hand? 2. Is the implant material and quality to a certified standard? 3. Is the implant cost-effective for both the practice and pet owner? 4. Is the implant readily available for immediate delivery? The choices we make may also have an indirect effect on our environment and community. For example, many implants are made overseas and have to travel up to 10,000 kilometres just to reach the UK. N2 UK have the solution. Our high-quality range of veterinary products are manufactured right here in the UK, helping you reduce your carbon footprint while supporting your local community and business. With over 4,000 product lines in stock, each manufactured to meet quality ISO standards and next-day delivery available, we can guarantee the efficient delivery of your products as and when you need them. For a cost-effective solution to your veterinary needs, visit n2-uk.com today.
Thanks, Paul, and evening, everyone. Thanks for joining us tonight for the talk. As Paul said, this is the first in 3, so we'll get started. So we're looking at small animal orthopedics and fracture management is the aim of this series. We split it into 3 parts. So part 1 is going to be understanding the fracture. Then we're going to look at constructs, grafts and casts as the second talk, and then we'll finish up the series with a talk on complications in fracture management, as well as running through some case examples. So the aim of these talks is to sort of give you an overview of fracture management. It's not going to be a comprehensive how to fix everything talk, but hopefully should give you some pointers of areas to look at, and the slides and each of the presentations will be online via eLearning Vet, so we can have a look at those as a point of reference. So first talk is on understanding the fracture. And the aims of tonight, we're going to run through a brief history, then we'll look at the anatomy and physiology, we'll look at how we image fractures and why we image them and what we're actually looking for, then we'll look at the physics of fractures and the implants together, and then finally we'll look at the fracture patient assessment score and the principles of surgery. So a lot to pack in, but we'll get through it. So first off, as I said, this isn't going to cover everything. These are some really good references to look at. We've got the AOVET and the BVOA with both associations there. That if you're really interested in orthopedics, especially fracture repair, then these are places to have a look at for some more references, as well as these books. These are really useful books if you're getting into fracture management. So a brief history. In people, and this is where it started, there's evidence of crude fracture repairs as far back as 4000 BC, and then there was a massive break in that timeline up until we got the introduction of general anaesthesia in 1846 for perhaps obvious reasons. Then we see it snowballing from there, getting the first surgery performed in the same year under anaesthesia. Then we introduced the idea of antisepsis, so we're reducing the risk of infections and complications from that point. Then we're getting x-rays. Then as wars continue, sounds like an odd thing to reference, but that creates a huge number of casualties, a lot of them with fractures, and that's a lot of patients to fix, and in one way or another practice your skills at fixing things. And we've progressed from there, from rudimentary external coaptation to fixation and then internal fixation, and all of these are sort of overlapping as well geographically. The biggest leap forward was just before the 60s, the AO or ASIF foundations were set up, and they've been a landmark in fracture management in both human and veterinary fracture fixation. In animals, the idea of fixing fractures was less important because, to be fair, if patients or animals couldn't do their work, as they were historically more work animals, then they would be euthanized. Typically speaking, horses were the first species that we really saw any evidence of this, going from wooden splints and plaster casting and special shoes, and it's progressed forward, keeping in line a little bit behind the times, but keeping in line with human treatment up to now. And in 1969, that was when the AOVET was founded on the back of the AO-ASIF Association, and there's a bit more of this in the BSAVA fracture manual, as we've referenced there. So simply, what is a fracture? And it's by definition a disruption of the continuity of a bone, and the vast majority of these are, as we'd expect, traumatic, but we can't forget the pathological fractures from endocrine, nutritional, neoplastic disorders, as well as in young animals that can have physeal fractures which appear to have little or no trauma at all. This is a really important point. The type, location, configuration, concurrent injuries, and the patient itself are all massive variables. So really, although you might see similar fractures, you're unlikely to routinely be coming across the same fracture every time. And that reference at the bottom there makes a point of that. 556 fractures of the pelvis found over 2,000 different type of fractures in 160 different configurations. So as we said, trauma, we're not going to go into trauma management as part of the talk. I think it's something to look at elsewhere, but being aware that because it is a trauma, we need to stabilize these patients, and we're not worrying about the definitive management of these fractures until we've got all of that under control, and any comorbidities are going to be important. Again, a couple of points. 70% of dogs with an RTA had, with fractures associated, had additional injuries. And 37% of dogs with a pelvic fracture had intra-abdominal injuries, most of which were hemoabdomen. So they're really good reminders that actually when we're first seeing these patients, although being aware of the fracture, it's not the first thing to be managing. So let's move on to anatomy and physiology. So you can see here, bones have got two functions, broadly speaking, mechanical and biological. And as an orthopedic surgeon, we're looking mostly at the mechanical side of things, so the support, protection, and locomotion. The minimal reserve is less likely, but occasionally we can see pathological fractures because of altered calcium homeostasis, whereas the other, whilst they are important for the bone as an organ, it's not something we need to primarily be concerned about. So if we look at the anatomy, we should know we've got the axial and the appendicular skeleton, as well as the heterotopic in the male dogs. And these are divided to the axial, which is the skull, the vertebrae, ribs, and then appendicular, which is any limb that's essentially hanging off of that. So scapula down and pelvis down. And then we can classify our bones. We've got flat, long, short, and irregular. Lots of different types of bones falling into those different categories. And we probably think of the long bones, or the classic diaphyseal, epiphyseal, and metaphyseal bones with our fracture management. But of course, any bone can fracture, and managing those is important. So if we look at an individual bone, and this is more of an example of a long bone, as we said, being aware of the blood supply that we can see on the right, it's got a lot of blood supply internally, but actually the blood supply is coming from a few points that enter the cortex of the bone and cross into the medullary cavity. And that's important to remember when we've got a fracture, because quite clearly a fracture anywhere along there is going to disrupt the blood supply. And that's going to be important when we're thinking about how these fractures heal. And then we've got the anatomical regions, mostly for points of reference when we're thinking of describing bones and what implants we're using, but also important to be aware of what's going on in each location. So we're looking at bone growth, so when they're growing rather than repair. We've got two types that tend to occur in union, but they're distinct processes. So we've got intramembranous ossification, which is the direct formation of bone, and then we've got endochondral ossification, which is mineralization of a cartilage template. And then we've got bone that can remodel. So once it's an established, fully formed bone, it is an organ, it is living. And as we can see there in people, the numbers are about 20 to 30% of bone mass being renewed per year. So it is slow turnover, but it is a living organ. The important bone cells for that are osteoblasts and osteoclasts, the blast creating new bone and the clast resorbing it. And this occurs via endosteal and haversian mechanisms, either along trabecular bone in the first instance, or this osteoclast cutting cone. We reference those from remodeling because they also crop up when we're getting bone to heal as well. And there's some influences there on how bones form and their strength, Wolff's law, as well as endocrine effects. So the patient as a whole and its experiences in its lifestyle are also important. Bone repair, it's a highly organized process. So this is when we've had a fracture and it's healing. We rarely see a typical scar, if you think of it in that sense. So it's more like regeneration rather than healing, but it does take time, and that healing response will depend on the mechanical and the biological environment that the fracture is under, and we'll cover those in a bit more detail later on. So if we look at fracture imaging, classically we're probably all very familiar with imaging musculoskeletal system, or certainly the skeletal system with x-rays, and there's a good reason for that. It's widely available. In the scheme of things, it's a cheap modality. We've all got a lot of experience with taking x-rays and sending them and reading them, so we can share them with colleagues. We can get them sent for second opinions. The artifacts that are created by bones or implants is also less intrusive compared to other modalities. We've got lots of visual references. The anatomy is there to see, and we can reference that a lot easier in our heads compared to some of the three-dimensional techniques. And it's fast and less technically demanding. So the other things that we look at for fracture repair or other modalities, certainly computer tomography or CT is really invaluable for a lot of fractures. It gives us that superior spatial resolution. We'll see a couple of examples later, some nice pictures that show us that when we've got complex fractures or comminutive fractures, that this really comes into its own for giving us an idea of what's going on. And as a surgeon, understanding the geometry of your fracture and where everything is in space is really important for when you're essentially trying to put it back together. MRI does play a role. It's certainly very good at picking up some of the soft tissue injuries, but with the increased scanning times and the lower bone resolution compared to CT, it's not normally a first-line imaging modality for fractures. Ultrasound, as you're probably aware, is not really going to be picking up fractures. It can be used for looking at the periosteal surface of bones and perhaps looking at avulsions or physeal fractures in some individuals, but it wouldn't, again, be a first line, and X-rays are going to be more beneficial. And then scintigraphy, it can be useful. It's not widely available, so it tends to be left on the shelf a little bit, and there's also radiation limitations as well associated with it, but it does help to pick up if we've got a patient with lots of orthopedic conditions and we're not sure where a fracture is. It will certainly give us an idea where there's increased bone turnover, but as I say, it's very seldom used. So here's a good example of CT. We've got a 3D reconstruction of the fracture that's on the right. So on the left is the reconstruction. And there's a few still images there, but you can see that you can turn that around in 3 dimensions. It's like having it in front of you on the screen. Well, it is having it in front of you on the screen, so you can really get an appreciation of where everything is before you're entering into theatre. And then the multiplanar reconstruction on the right there gives us the 3-plane views of the fracture and gives us a better quantification. So we can see this is a humeral condylar fracture, a lateral humeral condylar fracture in this dog, so we can see that on the CT scan. And this just highlights the difference between CT and MRI. So if we go back, we can see the bony detail there on the right, and then on MRI, we're picking up great detail in the soft tissue that just wasn't there in the CT, but the bone quality or the resolution of the bone is not as good. So what do we want to do with our imaging? We know what modalities we've got. And essentially, it's going to be radiography for the most part. It's diagnosing and characterising the fracture. Then you're looking to assess your repair after you've been into theatre. And then you're looking to monitor how that bone is healing over time. And again, on the right there, a nice picture of that same lateral condylar fracture, pre-surgery and then after, immediately post-op. What do you want to do when you're getting your imaging? Well, if it's 3-dimensional, you don't need to worry about orthogonal views. But if it's X-ray, you definitely need to get orthogonal views, and getting the contralateral limb is always important as a point of normal reference, providing that other limb is normal. You want to get the joints above and below the fracture. If it's an articular fracture, then focusing on the joint itself. But if it's a long bone fracture, getting the joints above and below are going to be really important to check your alignment. You want to, for those trauma cases, image the abdomen and thorax, and perhaps you're doing that first as part of the definitive management for their trauma before you're looking at getting the diagnostic images of your X-rays, of your fracture. And of course, if you're thinking of sending these off or even sending them around the practice or showing them to colleagues, getting a radiographic marker for orientation and measurement is really important. So what do we want to do when we're describing our fracture? So we've taken an X-ray and we can see we've got a broken bone. You really want to be able to describe that so that you can share that information and talk about it. So if you pick up the phone and speak to someone, if you describe that fracture, they'll know exactly what you're talking about. So part of that is going to be your patient's signalment, any comorbidities, how the fracture occurred, and the fracture classification. And if we look at that table, that really succinctly describes the classification we look at. So describing the bone, the location in the bone, configuration of the fracture itself, if and what sort of displacement there is, and whether there's any contamination. And if you cover all of those in your classification, it's pretty easy to understand the fracture that someone's talking about. Specific classifications beyond just the location description. Hopefully you're familiar with the Salter-Harris fractures, open fractures, central tarsal bones, accessory carpal bones, Montague fractures and sacral fractures all have their own classification system that's worth just being aware of. So when we're looking at open versus closed, so closed has no communication with the external environment, whereas open communicates in some way or another, and that ranges from type 1 to 3, type 1 being just a small communication, whereas type 3 is marked communication with varying grades of contamination. And then pathological fractures, so neoplastic, nutritional or primary hyperparathyroidism, as well as congenital bone disorders. And these tend to be the ones you see under normal loading. So the dog hasn't done anything particularly strenuous, but we've suddenly got a fracture, and there's often secondary evidence of the underlying problem on your x-rays. So this is an example of those sort of Harris classifications. So in one way or another, they're involving the physis. So these are recurring in skeletally immature patients, ranging from 1 to 5, where we're either just along the physis, type 2, where we're physeal with a little bit of a metaphyseal component, type 3, where we're through the epiphysis as well as the physis, taking off a segment of the joint surface, and type 4, where we're going all the way through the epiphysis, through the physis and into the metaphysis, so a slice of the joint and the bone underneath. And then type 5s are not readily easy to recognize as they occur on x-rays, but they're the crushing injuries of the physis. So we worry about these because they destabilize the joint, however they happen, but especially types 3 and 4, they're going to cause some joint surface breaking the continuity of the joint surface, so they're a real risk of arthritis. So that's why we're worrying about those ones specifically. And type 5s, when we crush that physis, it stops growing. Not so much of an issue in single bone systems, but if we've got a paired bone system, like in the tib fib or the radius ulnar, we're going to see growth discrepancies between the two bones, and we can see angular limb deformities resulting. So we look at accessory carpal bones, and they're not particularly common fractures, mostly seen in racing greyhounds, hence where the classification comes from. And it's just describing where that fracture is on the accessory carpal bone. So again, if you're describing it, you know what you're looking for. If someone's reading your notes, they know what fracture's been repaired or approached. Same goes for central tarsal bones. Again, mostly seen in racing greyhounds, but we can see them in other dogs, of course. And again, this is just a separate classification of these. So if we look at radiography as our imaging technique, how are we going to use it to critique our repair and monitor healing? So the 4As is a system that's been proposed that works really well. And if you remember those, it gives you a checklist to run through. So what you want to look at for once you've done your repair and as it's healing until you're happy that it's fully healed is the apposition, the alignment, the apparatus itself, and the activity. And we can look at that using that fracture we saw earlier. So immediately post-op, we've got the apposition. So looking at the fracture line, referencing the image on the right to the central image there, and we can see that those fracture lines are well opposed, certainly the joint surface, and there's just a faint line of the supracondylar fracture on the lateral component there as well, highlighted by the red arrows. And then the apparatus, in this case, is it intra-articular? Do any of the screws breach the joint surface? Is the apparatus in the appropriate position? Have we got screws crossing the fracture line? Have we got screws too close to a fracture line? Have we not achieved as many cortices as we thought we had with our screws? And activities, clearly in this one, not something we're going to see because it's immediately post-op. And alignment, what we're checking for, of course, those orthogonal views for this, is making sure we haven't got a joint step, as the joint surface is the predominantly important part, second to the supracondylar component. So this is another example. This is a femoral fracture in a dog, and this was traumatic, and we can see it's comminuted there. So we're looking at the 4As again, so pre-op on the top, orthogonal views, and the same orthogonal views on the bottom. Instead of trying to get a rigid reconstruction, this has been, rather than anatomical, we've aligned this. There's been a reasonable bit of reduction there, but we're not aiming for complete anatomical reduction. The alignment, what we're looking for in both of those views is essentially, is the knee facing in the right direction? Is there any abnormal angulation of the knee? And is it proportional to where the hip joint is? And if you look at the craniocaudal view of the post-op, you can see there's just a little bit of varus angulation at the level of the distal femur there. So this is 12 weeks. So looking at that again, and this is a good example because we can follow things along. You can see that our apparatus now, that's one of the things we're looking at. That pin has moved slightly, so intramedullary pin has migrated, and there's been a little bit more angulation. If we're critical, there's x-rays are slightly rotated, so that creates an artifactual appearance of a little bit more angulation there. But we have got activity at the fracture site, so we're seeing resorption and new bone formation as well. And then at some point we've taken the intramedullary pin out, and we're moving forward with the healing. So this is 5 months, so quite a long period of time. And the eagle-eyed viewers amongst you will probably spot that the first distal screw, you can see there's a bit of radiolucency around that in orthogonal views there as well. So they're the sort of ways we're looking at and using radiography to monitor our fractures after surgery and then how they're healing. So we'll move on to a big chunk of tonight's talk, which is the physics behind fractures, which may not be everybody's favourite subject, but it is important to have an understanding of the physics, or essentially the forces that the fracture's gone under to create it, and then the forces that we've got to neutralise with our repairs. So as we say there, bones and the implant bone construct, both of those undergo forces, typically through weight bearing. Of course, the faster we're bearing weights, so different gaits change in those forces. But it's dynamic. You think of the dog that's lying down that suddenly goes to standing up. There's suddenly a massive change in weight and weight distribution, and the forces around the fracture and through those limbs need to be recognised and counted whilst the bone is healing. And that's our job when we're picking implants, to make sure that we win the race against time, if you like, that we'll get the bone and fracture to heal before the implants wear out, because pretty much none of our implant systems are going to be completely infallible to wearing out over time. They're undergoing continued cyclical stress, and if the bone never heals, there's a good chance that most implant systems will end up breaking or failing in some respect. So what we're looking for is it becomes a shared load, with the implant doing most of the work to begin with, and as bone heals, it starts to take some of that load and becomes a united construct rather than just the metalwork that we've put in, if you like. But we've also got to prepare ourselves and make sure that we're not over-engineering it too much, and making sure that we don't get stress protection at the bone inappropriately, and osteopenia resulting because of that. So what forces do bones go through? Some pretty crude drawings there, but we can see we've got compression, bending, rotation, and tension on these bones, and they're never sort of pure forces. A lot of bones are on different sides of their bone and different stances, different periods of the gait, are experiencing those forces all the time. You can imagine a dog running and then suddenly twisting and changing direction. We've got a bone that's under compression and rotation forces quite quickly, as well as the tension from the braking force of doing that, and some bending as well. So bones are going through all of this all at once. Bones are pretty well adapted to do that. They're offset from the weight-bearing axis. They're cylindrical. They've got a curve to them, and it means that their orientation means they're rarely perpendicular to the ground. So what this means is that they're well designed for dealing with abrupt changes in force, as well as being an organ that can adapt to that. As we mentioned earlier with Wolff's law, they can change to the forces that they're under. But what we generally set up is a tension and compression side to a bone when it's under compression, or under load, sorry. So we've got the compression on the concave side, and then on the convex side is under tension. And that's worth remembering when we're looking at placing our implants, especially plates. So what fracture patterns can be resulting because of this? So if we've got compression, this is where we end up with our transverse fractures, and bearing in mind this is if we have just a pure force exerted on a bone, which is rarely the case, so that's why we see different shapes and sizes of fractures. But compression leads to these transverse fractures. Bending, we see these little butterfly fragments coming out. Rotation, more likely to lead to our spiral fractures. Tension, more of a complete transverse rather than oblique fractures that we see with compression. And bending and compression leads to a larger butterfly fragment, or sometimes we just see the sort of multiple comminuted fractures or multiple segment fractures. And then if we've got a high energy fracture, it becomes comminuted. And the way to think of that, as you can see there, is we've got lots of fracture lines and lots of bits of bone, but essentially we've got a gap that's not supporting any weight. So best to think of it, rather than lots of different fractures, as just a gap in the bone. So looking at forces, these are important when we're thinking about our implants, but one of the important ones being stress. So when an object is subjected to a force, which is force over area, it creates a stress. And this is proportional to the area it's applied across. So thinking of that with our implants, we can increase the area safely by not using too big an implant, then we can decrease the stress. And that also is worth bearing in mind when we're looking at the bone that's fractured as well. So bending is something that bone does. It's also something that our implants will do. And it's hard to think of implants because they're dynamic and quite complex structures. But if we think of things as either a beam or a cylinder, then we can look at the area moment of inertia, or when something is being bent. And that's essentially the resistance to bending. And again, if we respect these formulas, it's simple geometry and mathematics, or not necessarily simple, but it's a mathematical function. And if we're respecting that, then we can understand how changing our implants, even just the orientation. So if we go from placing a plate flat onto, let's say, the radius on the cranial aspect, and we're getting it bending along its face as the fracture's healing. If we were then to put that laterally and it's bending along its edge, we've suddenly increased the area moment of inertia that it's going to be able to use by doing nothing other than changing the location of that plate. So bearing these things in mind is important. And then the polar moment of inertia is in reference to cylinders. So instead of beams, which we can crudely call our plates, if we're thinking of cylinders, intramedullary pins and screws, extra ESF pins as well will be falling into that category. That's proportional to the radius. So a small increase in the radius is going to lead to a massive increase in the resistance to torsion. So again, just simply changing the size of our implants by a small amount can have a big effect on its overall capacity to resist the forces that we're trying to neutralize. Strain is really important. This is something to think at in our implants, but also at the fracture gap, because strain is an expression of the change in length over the original length. And we'll go on to talk about how in small gap areas, so if we have a fracture that's just got a small gap, it's got a high strain environment, so that the implants are sharing that strain, and the cells that are trying to heal our fracture are also under a lot of strain. Whereas if we've got a big gap, then the strain environment is far less, because unless that gap suddenly compresses itself down completely, the change in length over the original length is far less. And I'll show you that in a couple of slides' time. Different materials perform differently under different forces and different stresses. It's important, as we said, bone is what we call anisotropic, so it has an ordered internal structure, so it behaves differently under different directional loads. Whereas metal is isotropic, so it has a small and random internal structure, which means that the load direction does not necessarily change the behavior of the cells. Of course, if we're trying to bend a plate on its face versus its edge, that will be different, but it means the actual material that object is made of, bone versus metal, and how it behaves is slightly different. What we're doing when we're creating fracture repairs is we're creating a composite, so we're taking two materials and putting them together. So a plate on bone, for example, or external fixator, no longer is metal and bone. There's two separate entities. It's the two together, and we have to understand how they're going to behave in concert. Stiffness is another force that we need to think of, or factor rather to think of, and it's the force required per unit length of deformation. So how stiff something is how much force it takes to change its shape. And that will be either elastic, if it withstands that force and then goes back to its original shape, but if we exceed that elastic limit or the yield point, then we'll end up with plastic deformation. Again, if we've got a plate that we bend a little bit, it'll snap back into shape. If it suddenly goes through a massive force, it's going to end up completely bent and it's undergone plastic deformation. Understanding how much material, how much force or how much stiffness this material has when we're putting them in the body is important, because we can get different materials for making our constructs, and we've got to know what they're going to go through to choose whether they're appropriate to put in that situation. So this is a way to think of it. Young's modulus is the way we consider, or is the physical representation of stiffness irrespective of size. So it doesn't matter whether we've got a femur, whether we've got a metatarsal, same as whether we've got a stainless steel girder or we've got a 1.5 millimeter screw. The Young's modulus is representation of stiffness. So bone is not particularly stiff compared to our implants. And titanium is stiff as stainless steel, and typically it's 316L steel that's in our implants, certainly in plates. So understanding that, it makes sense of why we're using these types of implants to protect our bones, because they're massively stiffer than the bone itself, so they're going to be able to protect it from those forces. But that's not a given. We can still see implant failure. Another physical constant to think about is moments. So moment is a force exerted along a distance, and that's proportional to force times distance. This is important when we're considering the implants that we're using because of where we're placing them. And as we can see with that seesaw at the bottom, we've got let's call it a 10 kilogram weight 2 meters away from our fulcrum, or the center of the seesaw, and then we've got the 20 kilo one 1 meter away, and they're both exerting the same force and balancing that seesaw, which is perhaps something we remember from sort of GCSE physics or other things. But again, we need to think of the fulcrum as the fracture gap in some cases, and those forces as being the screws, and the seesaw itself as being a plate. That could be the bars on the ESF that you put in, and the force being the pins that we put on there as well. So again, just thinking about how these things are going to behave under different loads. So I mentioned earlier, we've got Wolff's law, so that's how bone remodels in response to load or lack thereof. And just to reiterate, the strain, the change of length of the original length. And this goes on to make that point that I was saying earlier, in that we need to have a certain strain environment, which is a term that we're familiar with fracture repair, because the level of strain affects the type of tissue that can form. If we have a low strain environment, then bone can form, but if we're anywhere above 2% strain, we're not going to see proper formation of bone. 10 to 15%, we're going to get intermediate tissue, and 100% strain or thereabouts is granulation tissue. So what we expect is that we'll be able to reduce the strain of the environment as healing occurs to get us down to a level of bone there, so a low strain environment. But if we never fully reduce the strain environment, we're going to stop along the way and not get bone forming. So this is a way of talking about that strain, hopefully making it a little bit clearer. So we take our fracture or our bone there and create two simultaneous simulated fractures in there, a 10 millimeter gap and a 20 millimeter gap, put both of them in a vise, and then we compress that vise by 5 millimeters. You can see that the 10 millimeter fracture gap has reduced by half of its size, therefore its strain is about 50%, whereas the 20 millimeter gap that's been reduced in 5 millimeters has only lost 25% of its original length, so it's under half the strain, although it's been put in the same situation. So we need a low strain environment, as I said, to get bone forming. And if we've got a low strain environment, we can get direct healing. And when we've got a high strain environment, we get indirect healing. So direct healing being the creation of bone directly. And if it's almost completely perfectly in contact, we get eversion remodeling. And if we've got a bit of a gap, but not more than 1 millimeter, then we get intramembranous ossification. In converse, if we've got a high strain environment, so a big gap and it's very flexible, then that's when we see this typical sort of callousing formations. We get granulation tissue that forms first, and over time the environment becomes more stable, and we end up with progressing through the fibrocartilage through to bone. That's important for us as surgeons when we're looking at repairing these, because we have to understand the physics that are currently being encountered and the ones that we expect to be encountered, choose a repair to suit that. Then we create the optimal strain environment or manipulate it to our advantage, and then use implant constructs that will outlast that healing time, knowing that how we expect them to behave in that environment, and then execute the surgery that we've planned. However, there isn't a perfect strain environment, which makes it hard to be certain every time that you've got the right construct. So a lot of it is based on experience and knowledge of how these things occur. And it's not necessarily personal experience, it's everybody's experience, with a nod to something like the Asepsis Foundation that have taken that experience and been able to set up a lot of guidelines to repeatedly get fractures to heal of different configurations. So ultimately, if we're reconstructing our fracture, it needs rigid fixation and minimal gaps. We're going to get that direct bone healing. And if the fracture is bridged, i.e. it's comminuted, or we're not looking to get a complete reconstruction, then we need a fixation that can stand a lot of force for a prolonged period of time, because we're going to take longer to heal. And this is the principle of either absolute or relative stability, absolute being complete rigid fixation with minimal or no gaps, and relative being these slightly more elastic situations where we're allowing a larger gap to heal over time. So that's the physics, hopefully sigh of relief from some of you, but we having an appreciation of that will help when we're looking at building our constructs, and that's something we'll cover in the second talk of this series. So we'll move on to the fracture patient assessment scores, and then we'll finish off with some principles. So the idea behind this is that we assess every fracture and the patient attached to it, so that we can give it a score, so that we can help plan our repair. Because every fracture is individual, we've got individual situations with the individual patient, the owners that are associated with the patient, and the fracture and how it occurred. And we've got to think about all those things before we make our plan to counteract all of those. And the classic 5 Ps is really important in this situation. So what are the things we look at? We've got the mechanical, the biological, and the clinical factors in this patient assessment score, scored on a scale of 1 to 10, 10 being better, so a low mechanical score or a high score is a low risk, whereas a low score is a high risk. Just takes a bit of thinking about. Gives yourself an overall score if we look at all three of those components, and then we can therefore plan how to approach this and what constructs to use appropriately. So mechanical forces, this is the construct, the bone as well as the implants that have to adequately resist for healing. Then we've got the biological component. As we say, this is the things like the vascular supply, the patient's systemic or global status, whether there's any comorbidities, whether there's any drugs like steroids that this patient is on for, let's say, concurrent skin condition or something like that. And then finally, clinical. How compliant is our patient and our owner going to be, because that might change the things we look at using. So if we can get in the habit of doing these for every fracture, suddenly you can plan your fractures a lot more concisely and consistently, and hopefully get a good outcome for that fracture in that patient, rather than just pattern recognizing every tibial fracture getting X sort of construct. So here's some of the examples that might make a low or a high mechanical, biological, or clinical score. So we can see some of those things we can't change. So you're going to get a low score if you've got an overweight or a giant breed dog. Well, that's not going to change in a hurry in either situation. So we're going to have to address that. Whereas if we've got a small breed dog, it can always be slightly easier from the mechanical point of view. It doesn't make the surgery any easier. Things like multiple affected limbs, pre-existing disorders, all of those are going to give us a low score. From the biological point of view, if we've got a low energy fracture in a metaphyseal area, so a nice rich blood supply, with no damage to the soft tissue, we're going to be starting these higher scores, especially in young patients that are healing really well. Versus the other end of that spectrum, where we've had a high energy fracture, perhaps it's open and we've lost soft tissue coverage, or it's in an area where there isn't much soft tissue coverage. In an old patient that perhaps has diabetes as well, then we're going to be start worrying about the score that patient's going to get. And then finally, both patient and owner, how compliant are they? Have we got an owner that's going to stick to your instructions, and have we got a dog that's going to listen to them, or is it the opposite way around, where we've got an absolutely crazy dog or an owner that just doesn't really seem that interested in keeping the dog still for the next 8 to 12 weeks? And once we've got that score, we can see that if we've got high scores, we need to use less fixation, or fixation that doesn't have to last for as long, because we're in a favorable healing environment. Whereas if we've got those lower scores, then we starting to think about using really strong implants that are going to resist a lot of forces for a long period of time, to allow that fracture to heal with hopefully no complications. And some of you are probably already thinking, what do you do when you've got conflicting scores? Because we could have a situation where, like here, we've got a low mechanical score, but we've got high biological and clinical scores. So what we want to do is, when we've got conflicting scores, is focus on the low scoring category, and then amend our plan accordingly. So if it's the mechanical side of things that are low, then we've got a good healing condition. So we just need to focus on good mechanical support that doesn't need to last particularly long. So in this instance, perhaps things like external fixators will be absolutely fine, because we're not worried about pin loosening or those sort of complications. If we've got a low clinical score, then it's our patient and our owner that we want to worry about. Perhaps we want to use a really robust fixation for a short period of time where it's appropriate, and avoiding things that require owner compliance or the patient themselves get injured. So external fixators, coaptation, or bandages are going to be less likely for those perhaps obvious reasons. And finally, if we've got a low biological score, then we really need to stimulate healing. So we're trying to be as sympathetic as we can. That's always a goal as a surgeon, to be sympathetic, but being extra aware, and perhaps amending your approach to be doing that, or changing your construct, so that you're not causing any more soft tissue damage than you have to, and then thinking about how we might be able to stimulate the healing response for these guys, such as graft or controlling infections, etc. And additional factors to consider are the patient's function. Have we got the happy-go-lucky lap dog, or have we got the athletic or working dog that the owner really wants to get back in for the next season, or has got a race to run, and there's a lot of pressure riding on that? And the prognosis varies. I think it's important to say, we all say we fix fractures. Perhaps that's a little bit misleading. We repair them, but fixing them implies that it is a mechanical function of taking something broken and getting it back to normal, and making sure that owners are aware that although we'd expect that to happen in a large majority, is not always the case. That is really important. If we've got articular fractures, letting owners know that this is going to result in degenerative joint disease. I think in that study there, if I remember rightly, it's about 100% of the articular fractures went on to get a degree of degenerative joint disease. How debilitating that is always variable for patients. We know that with osteoarthritis, but it's important to let them know that if we've got an elbow fracture, condylar fracture, there is going to be arthritis developing in that joint. And it's not going to be without complications. Sometimes things go well and sometimes they don't. When they don't, it's always our job to reevaluate ourselves, and a large amount of time in retrospect, it's a technical failing of the surgery, if we're honest. And again, owners need to be aware of that. Once you run into complications, the get out of jail free cards become a little few and far between, and trying to repair that or stop the complications can be hard, or in some cases not possible, or what it requires is something that owners or the patient are not prepared for in whatever sense. So it's always important to have that conversation on the outset with owners as well. So principles for surgical management. The golden rule is knowing your patient's condition and intervene on a fracture when it's patient's best interests, because an exemplary repair is worthless if the patient doesn't survive. It can sometimes be a bit of a running joke, but actually being aware of the fact that yes, you may be able to fix that fracture makes no difference if the patient's got a hemoabdomen because it's a pelvic fracture, or we've got traumatic thoracic injuries and it's not going to survive the anaesthetic with its traumatic myocarditis that it's developed. So being aware of that and just understanding that the fractures are exciting because you can see them and you know how you might be able to address them, but often they're not the first thing to prioritise for these patients. Don't be afraid to refer. Objectively consider the fracture, the score that you've just created, and your available equipment and expertise, and consider the patient first. We still do that in our practice. Sometimes if there's a fracture that I think my expertise aren't going to cover, I will defer to a colleague because that's in the patient's best interests. And it's a fair point to make that the most expensive repair is a bad one, because it often needs revising and it costs more, and we end up with biological costs as well as financial costs. So again, not saying that we shouldn't be repairing fractures. That sounds all very down in the mouth about it. Just being aware of these things, that's the whole point, is increasing our understanding before we get involved. As we said, trauma, so there's trauma in different areas of the body, perhaps there's multiple, so just thinking about those again, and referencing sort of emergency critical care books would be excellent places to have a look at if you're worried about how to deal with the trauma side of your fracture patients when they're coming in. But understanding that we can have trauma to the head, so either the brain or the mechanics of the feeding, both of those are going to be important. Perhaps the brain injury more immediately pressing, of course, but it's still the mechanics of feeding. We've got to get these things or these patients to heal, and that's going to be important. Trauma in the thorax could be pulmonary, it could be cardiac. We've got traumatic myocarditis, lung contusions that perhaps aren't obvious from the outset and take a few day or so to start coming out, up to 72 hours, as well as bleeding, torsion, damage to the simple mechanics of breathing. Any of those things are going to be a real pressing issue. Bleeding in the abdomen or urinary obstruction, again, are going to be immediate issues, as well as torsion of any of the other, for example, the small intestine. If we get a torsion there, it's going to be a big deal. Skin wounds, although that's not immediately life-threatening, if we've got loss of the soft tissue envelope around that fracture, then that's going to be important for our plan. And concurrent conditions for our patient. Has it got other orthopedic, neurological or vascular injuries to the affected limb or other limbs that are going to change how we want to do things? And it's important, as I'll probably come on to say, that the radiographs don't give us the whole picture. They show us the bone. We can get a really concise idea of what's going on in there, but we still got to be aware that there are soft tissues around that bone, and making sure that we've not got a fracture we can repair that has no blood supply or no nervous input to the limb, and we risk damage after the surgery. So when do we time our interventions? If we're looking at just the fracture itself, so ignoring everything else, intervention within 48 hours is normally well tolerated. So it gives us plenty of time to worry about getting these patients stable and ready for surgery and making our plan. There is a list there of fractures that perhaps require more prompt intervention, or perhaps a preliminary stabilization. So we need to get let's say the grade 3 open fractures, getting them stabilized with a temporary external fixator in a rapid period of time, prior to looking at doing the more definitive stabilization. In some cases, these early preliminary stabilization, go on to be the final stabilization, but we're just doing something initially to get them stable if we need to. So that list there gives us a good idea. Juveniles being because they heal very quickly. The longer we leave those, it does actually make the repairs a lot harder. And surgical principles, we should be familiar with the idea of Houster's principles, and that translates into fracture repair. We've still got to be, hopefully as you're getting the idea, the emphasis on being respectful for the soft tissues, because they're going to help how things heal. So atraumatic healing, maintaining our hemostasis, strict asepsis, so we're not getting infections afterwards that would complicate things, preserving the blood supply, that's really important for fractures, eliminating dead space, accurate apposition and minimal tension, all of those involved with the soft tissue approach to the bone. And the AO principles, and these are the important parts to remember for fracture management. You want to get accurate anatomical reduction where appropriate, and there's a bit of an emphasis now on biological preservation over complete reconstruction, and we'll look at the decision making in a second. Rigid stabilization as per the fracture, so making sure we've got a decent construct on there, getting the limb mobilized early and safely. We need these limbs to be weight bearing to prevent complications and to stimulate healing. We don't want dogs and cats running around on them, but we need them using them under gentle loading, and as we said, preserving blood supply. So let's look at whether this fracture is reconstructible. So yes, are you looking at that fracture on your imaging and saying, I can put that back together? If the answer is yes, you then need to be thinking, should I put it back together? Because if it's a transverse fracture, then yes, because we're going to get bone loading between the implants and or load sharing between the implants and the bone. But if it's a highly comminuted fracture that you think you can probably put back together with a lot of orthopedic wire and a lot of plates and a lot of screws, perhaps it's not the one to be reconstructed. And if you're looking at it and going, no, it's not reconstructible, then you're looking to go on to a relative stability or a biological osteosynthesis approach. So that's essentially the decision making. Is it reconstructible? If it is, should I be reconstructing it? As in, can I physically reconstruct it? Or am I going to cause a lot of soft tissue damage and affect the biological properties of my fracture by getting in there and moving everything around when I can get it to heal by leaving it alone? So that anatomical reduction and rigid fixation, we need absolute stability. So that has got to be a really rigid repair. We're going to aim for direct healing. So we want to get our fractures reduced to less than a millimetre gap. If you're not thinking you can do that, then you're not going for anatomical reconstruction, or you need to change your implants to make sure you can. To do that, you've got to get your fragments compressed. So really, we're looking at lag screws, dynamic compression plates. You can, in theory, start doing that with external fixators and olive wires if you're using ring fixators, but that's getting into quite complex ground anyway. So looking primarily at lag screws and dynamic compression plates. You can use cerclage wire for it, but carefully. So if you think you need anatomical reconstruction and you don't think you can do it with those implants, then don't go for anatomical reduction and rigid fixation. Biological osteosynthesis is relative stability, so we're going for indirect healing. So what we're trying to do is maintain the length and rotational orientation of our bone, not worrying about the bits or the fracture component in the middle, and making sure that it's got an implant on there that spans that gap safely over a large area and then can let it heal over time. And this is when we're looking at our open but do not touch approach. And so that goes back to the question, should I reconstruct it? If you've got to get in there, open it, move around the fracture hematoma and put everything back together, then you probably shouldn't be. And that's when we look at the open but do not touch or minimally invasive approach. Here's a good example of that. The papers are referenced there. As you can see in the top, we've got a minimally invasive approach. So this will have been done with fluoroscopy under small skin incisions, not even opening the fracture site. And you can see we've got 2 large pins, a plate and 4 screws. And then if you compare that to the open approach for the same type of fracture, you can see far more in the way of implants, because you need that for having the cost of sacrificing the biology in that area. So as we said, the soft tissue and the blood supply, these are the things that supply us with the vascular supply for these fractures to heal. Once we've got a fracture, we've interrupted the normal supply and you get a really quick extraosseous supply set up, but be sympathetic to that. If we start stripping off muscle attachments and moving all the soft tissue out of the way to get our fractures to heal, we've destroyed all of that vascular supply, and it's going to delay or even prevent healing from happening. So we've just got to be sympathetic as surgeons. Sometimes in areas we've got to think about putting a blood supply in there, so compound flaps, or protecting the local blood supply with tension relieving supplies is important too. A hematoma, it's a really good way of thinking of it. It is precious. It is like gold. We don't want to be stripping that out of the way so we can get bone fragments together. It's got lots of immune cells, vascular supply, and inflammatory mediators in it. Try not to touch it unless we're getting everything completely rigidly healed. Leave that hematoma alone and leave it in the fracture. The way we reduce our fractures is important as well. It's going to be an aggressive approach to some of them. Some of them need a lot of force to get them to back into alignment so that we can get our implants on. And we can either do that open or closed. So open being visibly accessing the fracture side, and closed doing it from an area distance to the fracture. And that can simply be just by using physical manipulations with your hands, but we can also get different implants or instruments that are going to help us with it. Frames. Having an assistant is really helpful, and using things to temporarily hold things in reduction, such as K-wires or bone holding forceps, is going to make that a lot easier. But have a bit of a plan before you get in there. Fissures can be radiographically silent, so be careful with the bone so that you don't make the fracture worse. Especially in young bones, they need a tempered force. You don't want to go in there like a bull in a china shop. It's better to start off gradual and work up to it. And patience helps. You've got to fatigue the soft tissues around it as well, so just take a bit of time. Hopefully this doesn't need talking about too much. Asepsis and antibiotics. Yes, this is a surgery where we're going to have a long GA. We've got damaged tissue. We're putting foreign material in, so we're ticking the boxes for wanting to using prophylactic antibiotics, making sure it's something that is going to cover us predominantly against the bacteria that we're going to find on the skin, and typically that's a first generation cephalosporin or amoxicillin clavulanate. We're giving it 30 minutes before cutting, and then every 90 to 120 minutes during surgery until you're done. It's a bit more controversial about post-operatively. Certainly if you think you've broken asepsis, you need to be doing that, but it's not going to make up for using antibiotics is not going to make up for a poor technique. So making sure everything is aseptic is absolutely important. Changing gloves if you're prolonging your surgery, changing your instruments if you need to. And if you break sterility, look into it. Make sure you get it changed before we get back into the fracture site. Analgesia, again, really important. As we said earlier, we want early and safe mobilization of the limb. This is going to be really important preemptively and as well as post-operatively. Normally we're providing some level of pain relief, typically our non-steroidals for up to 3 weeks after surgery, maybe a little bit longer. And recognizing that if our patient is painful, it doesn't become immediately comfortable, then there is a problem there and we need to sort that out. These patients will be initially uncomfortable, but the pain should not be excessive. It should be manageable with analgesia, and it's not, pain is not something to use for exercise restriction in any sense. Unfortunately, people find that that's an easy way, in inverted commas, to keep patients still. It doesn't do them, it doesn't do the fracture, and it doesn't do the owners any favors at all, and that's not something to advocate. Post-operatively, another principle there, we've done our fracture repair, we looked at it, we're happy with our x-rays. Now what do? We said we've got the analgesia. Rest. We really need to keep these patients rested whilst we want them using the leg. We don't want it uncontrolled or high forces. So dogs is typically crate or a very small room if we really have to, but crate's ideal. Lead control toilet walks, and cats are far easier, and we can crate confine them with access to a litter tray with enough room to get up, move around, move between litter trays, food, water and bed, but being kept and confined in that crate. And you want to make a reassessment of your patient before you change the exercise plan. So don't start introducing lead walks until you've had a look at the dog and checked that it hasn't licked the surgical side and now opened the plate up, or there's not lots of swelling, etc. Rehabilitation is important. If you've got a physiotherapist you can refer to, that's even better, but making sure that again, we're respecting the soft tissues, the bone's on the way to healing. We need to make sure all the ligaments, tendons, joint capsules that have been involved, muscles are kept mobile and moving around that fracture site. Typically, we're radiographing these between 4 and 8 weeks. 6 to 8 is more of the convention, but it depends on the signal of your patient. If it's juvenile versus an adult, the repair that you've done, and if there's any problems, if you're concerned you're doing it earlier. So you want to put all that into motion. That's going to be the focus of our next talk. But looking at the fracture patient assessment score that we've created, knowing our surgical principles gives us the opportunity to make plan A with many backups, because not everything survives the first attempt in theatre. It gives you time to plan, be happy that everybody on the team knows what's going on. And a careful plan protects the local anatomy, improves our biological healing component of these fractures. It saves us time, prevents the dread or the fear of being lost. And there are plenty of standard approaches referenced in that book there on the right, so you can get a chance to be familiar with those before you get into theatre. So finally, this flowchart should just give us an idea that as these patients are starting to come into practice, we've got the initial contact and we're looking at how we need to move or handle them, especially if we're suspecting a vertebral fracture. Triaging our patient, performing the emergency stabilization at that point before we move on to getting the full history and the further patient examination for more diagnostics and screening radiographs, treating anything that we need to treat before looking at definitive fracture imaging, making our plan, developing that plan, and then getting in there and doing the fracture repair. So there's some take-home messages from today. I appreciate we have whizzed through a lot of areas there. And hopefully if you guys have got any questions, you've got time to stay and ask them, please do. More than happy to run through those. The talk should be up on the website at some point. Paul will give you an idea on that as well. And that gives you hopefully something to refer to and go from there. And there's the copy of the references of the books that I've talked about and a list of the references as well. And we'll move on to questions. So in that case, it depends on the patient and the way you've fixed the fracture. If it's a juvenile patient in the region of 4 to 8 weeks, sometimes by 4 weeks, some of those fractures have completely healed or radiographically healed, which is an important side point. Telling how a bone has healed on radiographs, we've got good indicators, and it's normally a good reflection of how well it's healed, but we're looking at radiographic rather than complete healing or known healing, but we expect them to be the same in most cases. If you've gone for indirect healing in an adult dog, probably in the region of 12 weeks, perhaps a bit longer, depending on if it was a high trauma or a low biology scoring fracture. If you've gone for direct healing, it will actually take longer for that healing to occur. Can take a good few months for that to happen in adult patients, but because we've got the sharing of the load through the bone and the construct, that's not necessarily a problem. What you're looking for is that you've got progressive signs of healing on your x-rays and that you've got evidence of bone activity showing you that it's healing. We'll talk about in the third talk the sort of delayed and non-unions, when you can see quite strong evidence in your x-rays there that we've got bone either not healing at all, so doing nothing, starting to die back, or failing to unite whilst trying to heal. But they're sort of rough times. I hope that answers your question. So I'll be honest, I'm not sure the acronym NS, I can't decipher what you're referring to. Presume you're meaning normal saline and an antibiotic through cells. So I think we have to be careful that there doesn't appear, as far as I'm aware, to be, and this is as far as I'm aware, a lot of evidence that we need to be bathing our surgical sites in antibiotics to get a positive outcome. It is something that in human surgery, they certainly do irrigate the surgical field, especially in things like knee replacements. They irrigate with antibiotics in an IV system, as you're sort of describing there. I'm not aware of it being convention, and I certainly wouldn't be looking to do it as long as I'm happy that I'm managing to keep my surgery sterile, and I wouldn't be using that as a reason to not be looking at I wouldn't be using that as a reason to make up for any breaks in sterility or perhaps poor techniques or breach of sterility in theatre. Yes, so it's going to be secondary to the underlying primary issue with the dentition, and you need to address that at the same time. So stabilising the fracture isn't going to do anything if we've got essentially osteomyelitis in and around that area, because we're just going to get failure or refracture after the implants fail. Yeah, so plate rod or pin plate constructs, as you can refer to them. We'll come on to that in the second talk. But yes, depending on the fracture configuration, you may want to. Certainly in common U2 fractures of the long bones, yes, it really does improve the mechanical aspect of your repair. So that's a good question. I suppose technically we've gone in there with the intention of not having that problem, but as we know, surgeries don't always go to plan. If it's a healthy environment and you've got less than 1 millimeter distance and you've got a rigid construct on there, then not necessarily. What you need to be aware of in that situation is if you have a uneven gap. So if you have a gap at the trans cortex and not on the plate side, even with a bone graft in there, you're at risk of things failing through high strain on the plate. Yes, your graft will hopefully increase or rather decrease the time to healing, increase the healing potential, but I'll probably focus on realigning the fracture and your implants rather than relying on a graft in that situation. But grafts can help, absolutely. Yeah, so deciding whether to double glove or not, you're absolutely right. There is a high risk of fractures, glove penetrations in orthopedic surgery, either from your implants or from sharp ends of bone. And sometimes it's on those we know that about 5% of gloves, I think is the right statistic there, are going to have holes in at the end of any surgery. So yes, sometimes I double glove. Personally, it depends for me on what instruments I might be using, what implants I might be using, and how long I think the procedure will be. I certainly change my gloves if I've been wearing them for longer than an hour. So we'll re-glove or over-glove if we need to. And depends if we've got a fracture that's in a patient that has other comorbidities, so diabetic patients, or has been on, let's say, steroids, absolutely will go in double gloved, but not absolutely all the time, every time, but it is factored into the decision making.